Now let's go into the three main modes, the full support modes, where the machine controls all the ways that the breath is being given to a patient, is the control mode or the assist control mode. The partial support modes can be SIMV with pressure support, CPAP with pressure support, or plain CPAP. The spontaneous ones could be spontaneous mode, CPAP mode, PSV mode, CPAP with a PSV mode. Let's now try and understand each of these modes, either volume or pressure, but the modes now. If you look at a control mode, in a control mode, the physician sets the tidal volume or the pressure. The physician sets either the flow rate or the inspiratory time. The machine starts the breath. The machine ends the breath. The patient is not allowed to change anything here. So this is a control mode. On a graph, how will this look like? You can see the pressure versus time and the volume versus time graph. You can see that for a pressure control ventilation, constant I time, constant pressure, each breath following the next at the start of the next inspiratory time. Even if the patient wants to take an effort anywhere here in the expiratory phase, the machine will neither understand it nor support it. The similar thing happens in a volume breath, where the tidal volume is actually delivered breath on breath on the I/E ratio, which has been set. Now, the next mode, which is slightly more synchronous with the patient, and when I say synchronous, it still does not allow the patient to do much, but at least now allows the machine to understand that the patient is trying to breathe, is the assist control mode. In the assist control mode, again, all the parameters are set by the clinician, either the inspiratory pressure or the tidal volume, the flow rate or the inspiratory time, the I/E ratio. The breaths are initiated by the machine. The breaths are ended by the machine. Now, what is the difference between an assist control mode and a control mode? In an assist control mode, if you can see the slight negative deviation, the machine allows the patient to actually try and trigger in the expiratory phase. So there is an additional parameter which we spoke about earlier called the inspiratory trigger. The inspiratory trigger could either be a pressure trigger or a flow trigger. Some of the other equipments have other modes of triggers. We will not get into it now. So once the patient has tried to pull either a pressure or a flow, the machine understands it and prepones the next mandatory breath, provided the patient has triggered. So what does this mean? If I've set an inspiratory trigger of -3 centimeters H2O, if it's a pressure trigger, if the patient is actually pulling in -3 and the expiratory time has not yet finished, the machine understands that the patient wants a breath. It prepones the next inspiratory to coincide with the patient's own efforts. So what is the help to the patient here? He does not spend work in breathing. There is no energy loss. As he's trying to breathe, the next mandatory breath coincides with his breath, so there is no energy loss. But the breath is as per what the clinician has set, either a volume or a pressure. Is this clear? Is this concept clear? I'll actually pause here for 30 seconds to wait for any questions. I'm seeing it on my chat window. I don't see any questions as of now, but I'll pause here because understanding the assist control and understanding why many physicians today prefer to start ventilation with assist control is important. So I'll wait here for 30 seconds for any questions. And Dr. Bala, if you see any questions, I would request you to just elevate it up to me so that I can respond.
Yeah, sure.
So if no questions, let's go forward. The third mode is the SIMV mode, which stands for Synchronized Intermittent Mandatory Ventilation. This is a combination of machine-given breath and spontaneous breath. So actually in this breathing cycle, either you can have a mandatory breath if there is no patient effort, or if there is a patient effort outside the trigger window, you'll have a spontaneous breath. If there is a patient trigger in the trigger window, you could have a assisted breath. And if you set a pressure support and there is a patient driven breath outside the trigger window, then you could also have a pressure support breath. So all kinds of breaths are possible in SIMV: mandatory, spontaneous, pressure supported, and assisted. So the advantage of an SIMV is that the patient's work of breathing is reduced. But to also put it on a converse, if the patient is triggering the machine often and you don't set an adequate pressure support, then the patient's work of breathing may also conversely rise up. So the appropriate pressure support, the appropriate rate has to be set when we are putting a patient on an SIMV. So if you actually see here, you can see a mandatory breath. You can see a spontaneous breath. You can see that in the trigger window, the patient has triggered, and you see an assisted breath that is being delivered to the patient. And if you conversely look at all three scalars, you can see that when the patient triggers, if it's not a supported breath, then the volume that the patient drives is completely commensurate with the pressure that he has displaced. Going forward, let's come to I would not call it the final mode, but the final of the basic modes, which is the Cpap mode. Cpap, by definition, is continuous positive airway pressure. It means that a constant pressure is being delivered by the ventilator to your patient. All the breaths have to be supported, have to be spontaneous here. The patient initiates the breath. The patient ends the breath. The breath could either be completely spontaneous, meaning that as much as the patient is able to draw, the patient gets against the flow, against the constant pressure. But if you set a pressure support, then once the patient triggers it, then he gets a pressure supported breath. So here it's a completely spontaneous breath. There are no mechanical breaths, and the breathing is at an elevated baseline. Now, if you see here, in most of our ventilators, we set a PEEP in the controlled or in the assist control breath, or even in the SIMV. Here, the PEEP becomes a Cpap level. So basically, physiologically, the PEEP and the Cpap would be the same here. There is an elevated baseline pressure. There is a continuous flow of gas which coincides to this particular pressure, or which actually generates this particular pressure, and the patient is breathing against it. So this is a fully spontaneous effort for the patient. Now we've talked about the modes. We also said that in the assist control and in the SIMV breath, there is something called a trigger, because a trigger is something that tells the ventilator that the patient is trying to take some breath on its own. So the trigger can either be a pressure trigger or it could be a flow trigger, and it's an inspiratory trigger. Some ventilators today in advanced modes, in spontaneous modes, also have an expiratory trigger. So a trigger actually is a variable that determines when the ventilator recognizes a patient's inspiratory effort. Now, I've talked here on the SPRE V200. I don't want to pitch the Philips equipment here. There is a separate trigger in these machines called an auto track, which I will not go into here because I want to keep focus on the basics which most of the ventilators have. So as I said, you have a pressure trigger and you have a flow trigger. Now let's try and understand what is a pressure trigger. The pressure trigger, the inspiratory effort begins with a contraction of the diaphragm. That is physiological. This contraction of the diaphragm will actually decrease the pressure in the ventilatory circuit, because you know that an invasive ventilatory circuit, is my audio clear now? Because I just got a message saying audio is not clear.
Yeah, it's better now.
Excellent. So here, because in a mechanical ventilator or in an invasive ventilator, the circuit is a closed circuit, meaning that the patient breathes from the ventilator and the patient breathes into the ventilator. So as there is a contraction of the diaphragm, there is going to be a drop in pressure in the ventilator circuit. So we set a certain value for the inspiratory trigger. The value could be -1, -2, -3 centimeter H2O, meaning that the drop in pressure for the machine to recognize this as a trigger has to be greater than the value that I set. So what are the most common mistakes that we can make here? We set a trigger that is too sensitive, and even if the patient moves, the machine is triggering, and then every breath is a triggered breath, and we call it an auto cycle. On the other side of it, we set too high a trigger, say -5, -6, -7, and even if the patient is trying to pull hard, the machine does not recognize it as a trigger and continues to give mandatory breathing. So setting off the trigger is an art that you have to do at the bedside. Look at the patient condition, look at the breathing pattern, and try and set a trigger that is most appropriate for the patient. As a thumb rule, between -2 to -3 is what most patients tolerate and are able to trigger well without the risk of an auto cycle. Now here, in a pressure trigger, once there is a drop in trigger in pressure, because the patient has to pull down this -2 or -3, there is a lag. And once the machine recognizes that the patient has pulled down to -2 or -3, then it opens up the inspiratory circuit and pushes in a flow of gas, and the patient's next breath comes in from there. So though a pressure trigger is good, but the work of breathing on a pressure trigger can be high, and there is a lag between the time that the patient triggers and he gets the flow for him to fulfill his demands. The next kind of a trigger here, I mean, this just shows you in a spontaneous breath or in an SIMV breath, when the patient has triggered and when the patient has not triggered. You can see here in the first two breaths, the patient actually breaches the trigger, so hence he gets a machine-driven breath. But in the third breath, the patient has not been able to breach the trigger, so the machine does not understand. And if it was an SIMV, then just the volume that is displacing would be delivered to the patient. Now, let's go to the next kind of a trigger that is called a flow trigger. Now, what happens in a flow trigger? Again, very similar to a pressure trigger, you set a value of the displacement of flow, which would tell the machine that if this flow is displaced in the circuit, the patient has tried to trigger. Now, in a flow trigger, there is a bias flow, meaning that even in the expiratory cycle, there is a flow that is going from the inspiratory side to the expiratory side. Normally, most machines have the bias flow of 5 liters per minute. Now, in this bias flow, it is, if the patient is not triggering, it starts on the inspiratory and ends up on the expiratory. But in case a patient triggers, what happens then? You start off at 5 on the inspiratory. Because the patient has triggered and there is flow available, the patient's immediate flow needs are being met. So the work of breathing is lower here. You are not flow starved. There is no lag between you wanting a breath and the machine delivering a breath. So as soon as you drag in the breath, if you breach the trigger, the machine knows that you want some additional flow and the flow is opened up. But even if you do not trigger the machine, your initial need for flow is being met by the flow trigger. So always, many of the clinicians feel that a flow trigger is more patient synchronous than a pressure trigger. But the flow trigger also has a converse effect of also having auto cycling, because if the patient starts, knowing that flow is available and starting to trigger it, or if you set a flow trigger that is too low, then the patient can very easily trigger the machine and then start getting into an auto-cycling. So this is your inspiratory trigger, your pressure trigger, and your flow trigger. Now, we talked about pressure support as one of the concepts. Pressure support is available in SIMV and in a CPAP breath. So what does the pressure support do? In a pressure support, we set an additional pressure support value, and this pressure support value will support every spontaneous breath that the patient is trying to draw on their own. Every spontaneous inspiratory effort is assisted and is assisted to a preset pressure level. However, the patient determines the rate, the number of times he or she will be triggering. The patient determines the inspiratory time. Based on the patient needs, the peak flow and the tidal volumes are driven by the patient. The only thing that the pressure support will do is, as the patient triggers the machine, it will give an additional pressure so that the work of breathing to displace more volume is lesser. So that is the pressure support ventilation. It could be an additional setting in both an SIMV and in a CPAP. So you can actually see here in a pressure support let me go back, I'm sorry. In a pressure support ventilation, you can see here that once the patient triggers, the machine actually drives to the preset pressure support value. This improves the ventilator patient synchrony. It augments the spontaneous tidal volume. It reduces the work of breathing. It also overcomes the initial resistive work that's associated with moving an inspiratory flow through the circuit. Let me pause here for any question. We are at the fag end of our 45 minutes. I do understand that we have 15 minutes for Q&A, but I also wanted to pause here to see if there are any questions in the slides earlier that I may address. If no questions, then there is always this confusion about what is PEEP, what is CPAP in invasive, and what is EPAP in non-invasive ventilation. Basically, all three of them improve oxygenation. All three of them support in recruiting collapsed alveoli. All three of them help in splinting the airway, ensuring that your airway doesn't completely shut, so that for the next breath, you have to overcome the airway resistance to open the airways and then push in the air. And all of these three redistributes the lung fluids from the alveoli to the perivascular space. So technically speaking, the PEEP, the CPAP, and the EPAP physiologically are similar. It is a constant positive pressure above the baseline that is always available in a ventilatory circuit. In a controlled or in an assist control mode, it is called a PEEP. In a spontaneous mode, it is called a CPAP. In a non-invasive ventilation mode, it is called a EPAP. Now, again, as I said, the PEEP is a positive end expiratory pressure. It is the application of a constant positive pressure such that at the end of the exhalation, the airway pressure does not return to zero. And it is used in assist and in SIMV, but in CPAP, it is called a CPAP. In a completely spontaneous mode, it is called a CPAP, or in a non-invasive mode, the S and the ST mode, it is called a CPAP. Now, I'll just give you a flavor of a high-end mode. I don't want to run into all the high-end modes. There is one mode that we hear about very often, multiple modes actually, PRVC and APRV. APRV, I just thought I'll just give you guys a flavor so that I can see more of you in the next meeting that we have where we talk about the advanced modes. Now, APRV could be a mandatory or a spontaneous breath. It's a pressure-controlled breath where you have an inspiratory pressure and an expiratory pressure. Physiologically, it is similar to a BiPAP breath that we hear about, bilevel positive airway pressure. But unlike a BiPAP, the inspiratory time in this is far shorter than the inspiratory time on this is far longer than the expiratory time, and it allows you to breathe as many times as you want in the inspiratory phase. Let's look at the no, the graph is in the appendix. I'm sorry about that. But if you see the graph, you will see a long inspiratory phase followed by a very short expiratory phase. So there is an explosive release of gas. So it also helps you in washing out CO2. So it's technically a bilevel positive airway pressure with a reversed ratio or an inverse ratio. And it allows you to spontaneously breathe in the inspiratory phase. Some ventilators call it APRV as a separate mode. Some ventilators directly in the BiPAP allow you to inverse ratio and allow you spontaneous breathing in the inspiratory phase. So if you have a BiPAP machine with an active exhalation valve, it gives you the same impact as an APRV. Now, we had talked very briefly earlier, we had also heard in the poll that some of the companies call the same mode as different. Now, if I look at all the terminologies of the APRV, it is called bivent in Mackay, it is called APRV in Draeger, it is called bilevel in a Covidian, it is called APRV in Hamilton. So every ventilator company would have the same mode in a different nomenclature. I pause here. This is the basics of the mechanical ventilation. We looked at the modes, we looked at the breath types, we looked at the volume control, we looked at the pressure control, and all the modes that can be driven by either volume or by pressure. Now I open it up to the whole audience for any questions.